Thank you for the kind introduction. And I will straightforward start my topic. That is the clinical workup for increased creatinine. So I would begin with the case, very interesting case. Mr. D, 66 years old male, who did not have any history of diabetes or blood pressure. He went on Haridwar Yatra for 10 days, absolutely alright before he went, and also happy when he came back. Started feeling weakness after arrival to home and consulted nearby. On medical checkup, he found to have hypertension of around systolic of 160. There were no other signs. His lab showed creatinine of 5.2 mg%. Sonography showed normal size right kidney and left small kidney. And he was diagnosed to have chronic kidney disease and straight forwarded for starting of dialysis. Now luckily he came to me as he was my distant relative. I again revisited the history. He had history of reduced urine output since last 1 week. He had history of reduced intake including food and liquid, and he has reduced appetite. He was taking etoricoxib from the day he started his journey to Haridwar, and still he was taking. He also was given losartan for the blood pressure as he was detected to have blood pressure for the first time. He was clinically dry and tachypneic. So labs were redone. This time urine routine micro was done. It did not show any protein or did not show any sediments. Creatinine increased up to 6.2, potassium was 5.8 and uric acid of 9.11. Serum protein, calcium, CPK total were normal, and USG confirmed the same finding as before. Here immediately the losartan was stopped, etoricoxib was stopped. He was started on IV fluids with soda bicarbonate and standard anticalamic treatments were given. He was monitored to have urine output daily and started on amlodipine for blood pressure management. Steadily improved over a period of 1 week. Creatinine came to nadir of 1.7. Further investigation revealed high PTH, that was 195. Hypertension remained but better with control by amlodipine, and he went home with the diagnosis of acute on chronic kidney disease. So beginning with the creatinine. So what is serum creatinine? Serum creatinine is just an effective measure of renal function. Elevated creatinine always suggestive of some degree of renal impairment, may be acute or may be chronic. So we should always think of differential diagnosis of kidney failure. Serum creatinine is affected by many factors. It is affected by how it is generated, how it is filtered, and how it is secreted in the tubular lumen. Also there are considerable variation in the creatinine based on the individual patient factor and time method of testing. The normal reference range for male is around 0.7 to 1.2 and for female is 0.5 to 1.0. Physiology, we always know that the creatinine is a marker of kidney function, but it is generated from skeletal muscle metabolism and it is freely excreted by the kidneys. About 5 to 10% of the creatinine is secreted in the proximal tubules. So creatinine excretion and secretion both help in the removal of the creatinine by the kidneys. So how will you evaluate the patient with raised creatinine? So we were taught during our MBBS period, history is the most important part, and history almost gives us diagnosis in about 80 to 90% of the cases. So we should begin with the complete history of the patient first. We should always ask leading questions because many a times patient do not give proper history. So always ask the drug history, whether the patient has taken any over-the-counter drug or whether patient is taking any drug for the hypertension. There is recent change of the management of the blood pressure medicines. Patient may be put on diuretics or losartan or telmisartan. Patient may be having long history of diabetes and perhaps the patient has forgot to given the history of diabetes. Family of history of the kidney disease is very important. Many of the patients have genetic disease. Recent history of volume depletion like diarrhea, vomiting, blood loss could be the reason for acute renal failure. Careful examination of the patient, especially in the young patient, signs of vasculitis, rash, diabetes, endocarditis, hypertension should be undertaken. And any history of undue physical exertion, suppose a normal patient goes for the exertion like in the gym, sudden exercise also may lead to acute kidney injury. Duration of the illness, usually duration of the illness is much more important for defining whether it is acute renal failure, rapidly progressive renal failure or chronic renal failure. According to the definition, chronic renal failure when the duration of the illness is more than 3 months. Acute renal failure, again it has two parts. It is of less than 2 weeks, and from 2 weeks to 3 months, it is usually called as rapidly progressive renal failure. Symptoms. We sometimes do not ask the symptoms of the patient, but we should remember the patient having acute kidney injury should have symptoms in weeks. Patient may have some complaints of oliguria, anuria, leg swelling, and new onset of hypertension, as happened in the case 1. In chronic kidney disease, patient may have longer duration of the illness. Patient may have weakness, anorexia, weight loss, and dyspnea on exertion. In RPGN or RPRF, that is rapidly progressive glomerulonephritis, patient may have history of cola-colored urine, rash, leg swelling, and new onset hypertension. Asymptomatic patient with rise creatinine can be due to early chronic kidney disease or past history of diabetes or hypertension. So the first test which we offer to the patient whenever there is raised creatinine is urine analysis. Hardly $100 test, but many a times it is not offered, which gives diagnosis which can detect proteinuria, hematuria, and active urinary sediments. Even when urine analysis is negative, we should always find extrarenal cause for the rise in serum creatinine. Proteinuria is usually indicative of glomerular etiology. Hematuria is usually indicative of again glomerular etiology or sometimes related to stone. And active urinary sediments almost always indicate glomerular disease or glomerulonephritis. So what do we see in urine routine? In urine routine, usually we see first of all the color. What is the color of the urine? Usually the dark color urine suggestive of dehydration or pre-renal acute injury. Maybe patient may have frothy urine in nephrotic syndrome. Red color suggestive of hematuria, and cola colored suggestive of glomerulonephritis. Specific gravity, again the most forgotten task by any clinician. Specific gravity usually ranges from 1.010 to 1.030, but high specific gravity suggestive of dehydration and low specific gravity suggestive of dilute urine. Turbidity, sometimes we can ask the patient ke urine dhodo thai che ke nahi, urine white aave che ke nahi. The turbid urine itself indicates it's maybe a urinary tract infection. Protein, sugar, bile salt, and bile cell pigments also give us indication about the various diseases. Urine microscopy, again urine microscopy is done on a sediment or after spinning the sample of the urine. We usually see for the WBCs. Normal WBC which we usually accept in patient is around 3 to 5 WBC in high power field, and in female around 5 to 10 WBC in high power field. RBC is usually absent in the urine microscopy. Epithelial cells can be present around 10 to 15. Casts. So cast is the most important, which gives indication about the disease. The casts are actually the cells which are mixed with the tubular contents or tubular protein, that is called a Tom's horseful protein. So cast are cells plus some tubular protein, and granular or coarse granular cast usually suggestive of acute kidney injury or acute tubular necrosis. Crystals, sometimes we see uric acid crystals, xanthine crystals, calcium oxalate crystals, calcium phosphate crystals. Those are suggestive of stone disease. Hematuria. Hematuria could be of intrarenal origin, could be of extrarenal origin. Intrarenal origin could be due to the renal stone, or sometimes maybe the glomerulonephritis can give to hematuria. However, the differential diagnosis can be made by examining the dysmorphic red blood cells in the urine. In old age patient more than 50 or 60 years of age, we should always keep in mind the bladder cancer or prostate cancer can also lead to hematuria. Proteinuria. The most important thing, proteinuria is a common indication of diabetic nephropathy. Other signs of diabetic nephropathy include normal size kidney or large size kidneys, lack of urine active sediments, lack of hematuria, and usually these symptoms can be managed better with ACE inhibitors or ARBs. However, patients who do not have diabetes and proteinuria, we should always think of a glomerular disease, and the patient should be referred to the nephrologist as early as possible. Active urinary sediments like WBC cast or RBC cast again are suggestive of glomerulonephritis. Patients who do not have any kind of diabetes, however, if proteinuria and GFR of less than 30 should also be referred for the further evaluation. Renal ultrasound, again a non-invasive test which can guide about the renal size, echogenicity, and the presence or absence of hydronephrosis. Whenever there is presence of hydronephrosis, the urology people should be involved. However, large kidney could be related to diabetic nephropathy, FSGS, myeloma kidney, or sometimes in AIDS patient. Small kidneys usually suggest some long-lasting kidney disease, or maybe patient having CKD, or those patients who are having cardiorenal problem or reduced cardiac function can have small kidneys on longer run. If there is evidence of obstruction, then refer to urology. If there is no evidence of obstruction, we should consider the size, echogenicity, and other things like renal artery Doppler can also be ordered if young patient with hypertension remains. Other lab tests we offer whenever there is raised creatinine are urea, electrolytes, bicarbonate level, sugar level, calcium, phosphorus, uric acid, protein albumin, and protein electrophoresis. Why? Usually we advise urea, and we check the ratio of urea and creatinine. Usually urea creatinine ratio of more than 20 or 40 sometimes suggestive of pre-renal acute kidney injury. However, urea creatinine ratio of less than 20 may be suggestive of chronic kidney disease. Electrolytes are very much important. Sometimes the patient may be taking losartan, or sometimes may be taking diuretics, Lasix ditor. This patient can present with the diuretic electrolyte imbalance like hyponatremia or hyperkalemia. Bicarbonate we usually check to rule out acidosis. RBS for the glucose. Calcium, phosphorus, uric acid, these are the markers sometimes when calcium is lower side and phosphorus on the higher side can be suggestive of chronic kidney disease. Uric acid usually in the acute event it is on the higher side, which is again suggestive of acute kidney injury. Protein albumin usually we suggest whenever there is nephrotic range proteinuria or even simple proteinuria and we are not clenching the diagnosis, we can advise protein albumin. Lower albumin could be found in nephrotic syndrome. This is the same slide. I would go for highlighting the factors affecting the serum creatinine concentration. Any kidney disease could lead to rise in the creatinine. As we know, creatinine is generated from the muscle metabolism. So whenever patient is malnourished or reduced muscle mass, should have less serum creatinine report. Again, those who are taking non-veg food or meat can have 15 to 20% rise of the creatinine. Medicines like trimethoprim, cimetidine, and cephalosporin, these reduce the tubular secretion of the creatinine. So serum creatinine can be raised in patient taking trimethoprim, cimetidine, or cephalosporins. Ketoacidosis, again a pre-renal kind of thing, can lead to increase in the serum creatinine. I'm not going into the definition, I'm not going into the ACR ratio. So the goals of the assessment whenever the creatinine is rise is, first of all, to establish the diagnosis. Second, whether it's acute or chronic kidney disease. Usually acute kidney injury needs immediate action, which is almost always reversible in 90 to 95% of the cases. Define if CKD, determine the stage of the disease and determine the etiology of the disease. Appropriate clinical management is indicated, and of course the central part is patient education. This is the chart showing how to approach the patient with elevated serum creatinine. It is not clear, but I can tell you, whenever there is elevated serum creatinine, always examine the patient first, take proper history, and conclude your diagnosis by history. GFR calculation is not always possible because there are various factors which affect the GFR. So history physical examination is the first step. Next step is the urine analysis. As I told you, it's a very cost effective test offered to each and every patient. We can have conclusion from that. And renal ultrasound can guide us for any structural disease. So any patient having hydronephrosis or isostenuria or sometimes hematuria due to past history of stone should be referred to urology.
Sir, 5 minutes left.
Just a minute, this is the last slide. A patient with active urinary sediment should be offered autoimmune diagnostic test. Patient having hematuria should have thoroughly work up for the urology and glomerulonephritis. Again, proteinuria and GFR more than 30 should have history of diabetes, blood pressure, and GFR if less than 30 should be referred to nephrologist. So to conclude, rise in the creatinine, always think of renal disease, may be acute or chronic. Workup includes history, physical examination, urine analysis, renal ultrasound, and other special tests if needed. Based upon these studies, further workup and/or referral can be undertaken. Thank you, sir.
Thank you very much, sir, for giving such a informative lecture in a very simple way.